We are live now.
You. Good afternoon, everyone. A very warm welcome to everyone who's joined us today, this afternoon. My name is Dr. Prashant Subramanian, part of the medical affairs team at Abbott Diabetes Care. We welcome you all to this interesting webinar with Dr. Manoj Chawla. This is the fifth and the final webinar under the series called Project Outreach. The first one was scheduled in November 2022, and it's been a fantastic journey looking at how we've evolved with the topics. We started with the basics of continuous glucose monitoring. We've then moved to understanding the data with continuous glucose monitoring. We did discuss specific to the recommendations and guidelines. We also had a session which looked at getting started with CGM, and it would be the best option for today to actually get into more tangible details into how do we get started. And by that, we have a wonderful speaker today, Dr. Manoj Chawla, who will be sharing with you the interesting cases which he's garnered over years of experience. And this would give you a lot of information into how best to initiate and follow up with patients who've been initiated on CGM or continuous glucose monitoring. Just to remind all of you, when you've attended all of the 5 webinars, you will receive the attendance certification from RSSDI. The entire webinar series is hosted under the guidance of the Research Society for Diabetes in India. We have a fantastic speaker today, Dr. Manoj Chawla, with medical training and specialization in diabetology. He is the director and consultant diabetologist at Leena Diabetes Care and Mumbai Diabetes Research Center. He's a consulting diabetologist at PD Hinduja Hospital, Raheja Fortis, as well as BSES Municipal General Hospital. He's the elected All India Executive Committee member, RSSDI 2022, and is the scientific chairman for Diabetes India 2023. He was also the organizing secretary of Diabetes India 2022. He is the honorary visiting faculty at D.Y. Patil Medical Sciences Institute and was awarded the RSSDI Fellowship and the Fellowship of the Royal College of Physicians of Edinburgh. He is the principal investigator across so many global multinational clinical trials for new therapies and devices. He's also part of the technology task force in the RSSDI. He has more than 25 papers in national and international journals to his credit, and is also the associate editor of the International Journal of Diabetes in Developing Countries. Before I hand over to the speaker, it's a gentle reminder that the question and answer function stays live. So I request all of you to post in your questions, which can be then answered by a distinguished speaker, Dr. Manoj Chawla. Dr. Chawla will now share a few cases, interesting cases, which can help build on your understanding of continuous glucose monitoring. And then we move on to an interactive question and answer session. So I request all of you to put in your questions, which can then be addressed towards the end of the meeting. Without much ado, I now hand over the proceedings to the speaker, Dr. Manoj Chawla, please.
Thank you, Prashant, and thank you, team Abbott Diabetes Care, for inviting me to share some interesting cases on CGM. And it's wonderful to hear about the entire journey of this module where participants have been taken through the basic understanding, the need, the clinical utility of CGM. And here we are in the final module with some practical cases. So let me start by sharing my presentation. I have quite a few cases, and I'll use as many as I can in the time that we have before we move for the question and answers. Great. I believe I'm seen in the, am I right? Okay. Is it full screen mode already? If somebody can confirm that.
Not yet, Dr. Chawla.
Not yet? Oh, that's surprising. I thought I was already sharing this. Huh? Okay, something is funny here. So I thought the presentation was already up there. Is the presentation seen at all or not seen at this stage?
Dr. Chawla, we can see the file, but not in presentation mode. Now, yes.
Yeah, okay.
Now.
Right, okay. So we move ahead with the cases here, and this is case study 1. So I'm going to show different scenarios and then have some thoughts on that, and of course then open it up in the question and answer. So this is the first case we're talking about where the outcome of this one was to reduce glycemic variability and improve the time in target. Talking about a 27-year-old male type 1 diabetic for a year and a half. He visited us when he did for the first time. He was on multiple shots of insulin, but complained of fluctuations in the blood sugar levels. And just a sec. He was advised to do CGM as he hasn't been doing that in the past. There were some financial restraints, and which is where we decided that we will at least do the professional CGM. And at this point, I must say that for individuals with type 1 diabetes who are on MDI or on insulin pump, the ideal means of monitoring for them is using the real-time CGM. So when they use the real-time CGM, they're actually able to take more insightful decisions, be it regarding their lifestyle or insulin shots. And that's the way of life which is ideal for them. However, as this individual was just getting started off, he wanted to use the professional one and probably a little bit on the cost saving. So if you see his medication profile, 3 shots of Aspart or Novorapid, 1 shot of Glargine or Lantus. His HbA1c was around 7.5, but he did mention that he would feel the ups and downs and there were fluctuations in the sugar. So what we did for him is we did a blinded CGM, and which, as we can see the results here, you see the entire CGM profile to be hugely variable. The time in target was 52%, was dropping below in the TBR 7% and 41% above target. Now, a lot of you who would have been part of this entire module would have understood that when you look at a AGP graph like this, the principle of managing such patients, especially type 1s, is that you don't go ahead and try and reduce the hyperglycemia to begin with. So the management of exposure actually comes later. What you want to do is reduce the variability, which means that you're trying to reduce the day-to-day, the inter-day variability. That means you want to try and get the graph to be a little narrower. The second thing you want to do is get it more stable. That means within day, if you're seeing the ups and downs, you want to try and get it into a more flatter line. And the third thing you want to do finally is reduce the exposure, which means that's when you're working on reducing the hyperglycemia. Because the first thing if you try and do is avoid hyperglycemia and you step up the dose or make changes, the chances of hypoglycemia actually worsen. So this patient of ours does the FGM, Libre Pro, gets the insight. We discuss the ways ahead, both in terms of lifestyle and medication. In the intermittent period, this patient is doing SMBG because that's the way they would prefer to monitor. But later on, again, uses the second Libre Pro this time. And you can see that he's improved in terms of his variability. But as suspected very often that when you try and correct the exposure, this patient is experiencing a little more hypoglycemia than he did earlier. So the TBR was 7%, which has increased to 10%, though his time in target has improved tremendously and time above target has come down. So from what I would say, a python in the beginning, this individual's graph is turning more into a caterpillar, and hopefully from the caterpillar, we are able to bring it down to a thin snake moving across the range. But you clearly are able to appreciate this improvement. We need to avoid some hypoglycemias in this individual. We move to the second case study, which is about picking up hypoglycemia. Now, hypoglycemia or time below range is actually very, very common in our patients with diabetes on therapy. And this could be for individuals which are at any HbA1c. Your conventional wisdom would have made us think that somebody with only near normal HbA1c may experience hypoglycemia. But today, with the constant and regular use of CGMs over the last few years, we know that hypoglycemia is an occurrence in patients even with a very high HbA1c. In fact, higher the variability, higher the glycemic variability, and higher the ups and downs, the chances are they'll end up with a high HbA1c. And that's why we should suspect hypoglycemia even in patients with high A1C and see the larger picture. So this individual, female, 69-year-old, diabetes for 3 years, her sugars in the morning, whenever she checked, ranged at 200 and above. The A1C was high, but little early in the mornings or in the middle of the night, she would complain of dizziness and similar hyposymptoms, but never really could check at that point. And she was on these oral medications. We see the combination along with insulin, and she was also known case of hyperthyroid and on methimazole for the same. So when we took the CGM and the AGP graph, what you are able to clearly appreciate here is the hypoglycemia in the nocturnal period. Now, this patient was dropping low on those few days, and we can see that somewhere between 2 o'clock in the morning till about 5, 6 o'clock, this patient on certain days is experiencing hypoglycemia. But by the time she would check her sugars in the morning, which would be 8:30 usually, they would find the sugars to be a little on the normal or higher side. And this does happen in a lot of our Indian patients. Elderly female doesn't check the sugar on their own, SMBG, they are not comfortable. They'll wait for their son, daughter, daughter-in-law to get up and get free and then check the sugars, which was happening at around 8:39 for this lady. And hence she could actually never pick up that she was going low, and they would feel that the morning sugars are high, so there is no hypoglycemia, and they would in fact look at increasing the dose of insulin, which would be pushing her into more hypoglycemia. So let's remember that you can pick up hypoglycemia in different A1C subgroups, and that's what is the fact, and you should have a strong sense of suspicion of hypoglycemia, or I can say that even forget having the strong sense of suspicion for hypo. It's important that you start seeing the larger picture irrespective, because this is a better means of showing, of seeing the movement of sugar through the day and picking up all the wrong excursions, both upwards and any down below range excursions. So here in the daily graphs, and then again, I'm sure you've been taken through the different reports that you get through the CGM, the AGP, the daily patterns, the traffic signals, and so on. So if you look at the daily patterns, daily graph readings here, you're able to appreciate at least 4 or 5 days that she's gone into hypoglycemia. And this hypoglycemia is rather significant, because if I go purely by the definition of significant hypoglycemia based on CGM, it is staying below 70 for a period of 20 minutes. So as described much earlier by Pratik Chaudhary and group quite a few years back, that what is meaningful hypoglycemia is at least staying below 70 or TBR below 70 for 20 minutes. And we can appreciate that this is a couple of hours. On certain days, this has been in almost 2 hours. This is much longer. So this lady was going into hypoglycemia. What was done? Her sulfonylurea-based OHA combination in the night was stopped. Her DPP-4 was optimized. Insulin was continued the same. All of this because it was clearly evident now that her time below target was significant in the nocturnal period. So coming back to a theoretical aspect, limitations of A1C, I'm sure mentioned earlier in the lectures. Though the A1C remains the key indicator for long-term diabetes complications, it, however, reflects the average sugar over 2-3 months, does not reflect the short-term changes or excursions, which are actually important for us to figure out. So A1C does not reflect either hypo or hyperglycemic excursions. It fails to identify the magnitude and frequency of intra and interday glucose variations. And of course, all the interferences that we are aware of with HbA1c estimation, be it anemia, hemoglobinopathies, iron deficiency, all of these will have limitations. So we move to our next case. An 80-year-old male with type 1 diabetes for over 30 years, somebody who's using real-time CGM on a regular basis. You can appreciate from the black-colored Libre monitor that this individual is using the Libre Freestyle, the real-time CGM. Patient's HbA1c Now, this I have put up this case because it's interesting. One, the individual is elderly. You may not have an HbA1c target of 7% and below necessarily. His A1c has remained 7.7 and 7.8% throughout. Somewhere in his mind, he's always been passionate about good control, and he used to see a 6.7, 6.8 earlier, but was upset that his A1c has constantly remained in 7.7, 7.8, and which is where we suggested, and he had heard about this Libre Freestyle, and he said, "Doctor, I would like to use it." I said, "Fair, let's start doing that before making any changes in your therapy." Now, what does this indicate? Of course, what this shows also is the fact that a lot of patients do not have access to the software, and we know it's not really available here, though there are some downloads possible which people manage. But so what he was doing, and to convey the message to us, he would take photographs and pictures of his monitor and send to us. And as you can appreciate here, that for this gentleman, his time in target is 84% in the last 14 days, 79% in the last 30 days, 84% in the last 90 days if you average out. Somebody who's been using this continuously. No time below target range, and time above target in the permissible range. Now, my question to you, if we were sitting across in a room and conversing, would be, what do we do for such an individual? He's 80 years old. His time in target is more than 80% most of the times, without any time below range, and A1c is 7.7, 7.8. Do we really bother about HbA1c? So such is an individual where we know that his HbA1c would not be an ideal indicator. You look at his daily pattern graphs, and you do see that his sugars remain largely between 120 to 160, 170, and hence he's not going much above range except during this period. But you look at the overall 90-day period and the 14-day, there is a little surge in the evening time that you see, but the rest of the time he's within range. I would say just let it be. And this helps in the patient also to get convinced that I don't need to push. My time in target is so well that I need not worry that much about getting my A1c necessarily to below 7%. We move to the next case study 4. And this is, again, I would have loved to put this as a quiz question to all of you sitting there. That tell me what is the difference in both the images on the left and the right that we see. And I'm actually going to pause for a minute. And though we are not interacting right now, let all of you glance at this and see if you can put, of course, the question options are available. If you want to tell me the difference in the chat box, we'll appreciate that, and we'll mention out your name at the end of this. If any of you want to tell me what is wrong in this download image, which has been actually corrected on the right side, and let me take a minute's pause. So any of you who can figure that out, please put it in the chat box with your comment. Now, which gets me to an interesting part which I must communicate. So all of you who are encouraging the use of CGM, and I'm specifically referring to the FGM, whether it's Libre Freestyle or Libre Pro amongst your patients, always give importance to the target range which you are setting up. So when you're going to download the data, you will, of course, have the means in the Libre Pro software to choose what range you want to, and it need not be preset. But for those who are going to be having monitors, and you see a lot of our patients, picking up the monitors because this is directly available for them, or understanding, or some friend told them, and most of them underutilize the options of what is available to them. They'll only look at the sugar value. They will not look at the patterns. They will not look into their AGP profile, their time in range profiles, and so on. But most importantly, they will not even change, or they will not get into the correct time range setting. Somebody will change it to whatever they feel is right. So this is where you are able to, when you start seeing the report, look at the target range. So this individual has kept the target range between 100 and 140. Where did they get it from? Well, read it somewhere. No. So what is the recommended target range? It's 70 to 180 for all your patients with type 1 and type 2, except in pregnancy, where it should be ideally 63 to 140. But again, we may have some issues there that our monitor may not actually allow the settings allowed to bring it to below 70, which ideally should be seen between 63 to 140. But here, a well-controlled individual, what are the other things you see in a real-time CGM report? So this is the download of the real-time CGM. You'll see the average sugar, you're seeing the percentage above target, in target, which of course change the moment we change the range. And this is ideal that this one is spending 96% in target. If I would have blindly seen this one, I would have said, oh, only 49% in target. And patient is going so much below, is going into hypoglycemia. You correct the range and you realize patient is not having hypoglycemia, and hence the range is important. You also then able to see the sugar events, but other important aspect to see is the number of daily scans average. And you should encourage your patients, especially type 1s, to scan more. There are enough studies which have shown the higher the number of scans, right? Because this is at the end of the day, the intermittent scanning CGM system. It doesn't directly relay the data, which we know the further generations of the CGM are doing. But this one still requires constant scanning, and hence encourage more scanning. Even if it's 20 times, 30 times, it's fine. The more they scan, the more action they are able to take to their dosage and their lifestyle. We move to case study 5. 75-year-old female with diabetes from last 35 years, persistent A1C, constant A1C, which is in the 7.7, 7.8, irrespective of changes made. Complaints of giddiness at night, but fasting sugars are normal, hence CGM recommended. A little similar to our initial case 1, I think, this individual. And then we do the CGM. So she's again experiencing hypoglycemia in the 2 to 4 period as seen. However, by the time she wakes up, there could be an aspect of somogamy, counter-regulatory hormone release. But by the time the patient is waking up and checking the sugars, they're finding the sugars to be on the higher side. And that's where I again repeat that an A1C of 7.7, 7.8 doesn't always mean the sugars are high. Typically, this patient was having hypoglycemia in the night, a little hyper post-breakfast, which is another typical problem in Indian patients, and then some surges. Also, to remind all of you that have joined in, that estimated A1C, which is actually a wrong term and very often, and it's now been corrected in the Western softwares, at least, to GMI, which is glucose management indicator, is only an indicator of what's happening to the sugars during those days with minimal projection. It does not mean that the HbA1c is 6.4 or the patient will land up with HbA1c 6.4 at the end of few months. So we need to learn to ignore the A1C part here because that's not truly reflective of what the A1C is. We look at her individual readings and we can appreciate the hypo in the early part of the night on a lot of days, and then the huge surge in the morning. Now, this, of course, was getting missed without a CGM. It's easy for us to tell patients to check their SMBG, but what time do they check? Do they check at 3 o'clock in the night, 4 o'clock in the night? And if somebody does on a particular day, like this day, even if the patient would have checked the sugar in the middle of the night, would have found the reading to be 90, 100, and you would have said that's fine, would have missed, because you can't motivate or tell the patient to get up every night and start checking the sugars in the middle of the night, especially for a person who's working. So the CGM really picks up the stuff. We move to the next case study, which is again the use of real-time CGM, as you can appreciate. Now, this patient had the fear of going into hypoglycemia in the night, must have experienced some hypoglycemia earlier, but this patient then used to just start eating in the night because of the fear that, no, I'm going to drop into low. So when she saw us, we said, let's really figure out if you're going into low, what's the point in defensive snacking, which will add to your weight and your overall sugars, right? So we do the real-time CGM, and what we identify here is that this patient is not experiencing hypoglycemia. How we are able to help, as you can see, she's quite paranoid, and which is good for her to improve, because see the number of daily scans, 43 daily scans. She's of course remaining above target, and very often she was just snacking and because of the fear of hypo, actually snacking and pushing herself into hyperglycemic excursions. And this is a closer look at what was happening with your individual readings also, you can see, and what's happening in the night. So if you look at the night period, because on the real-time CGM, again, she's able to see now, earlier first few days, she would start seeing the readings which were earlier 190s, 200s come down to 111, 106, and she would start snacking that I'm going down. Some of these patients on the real-time CGM have actually to be taught that this is a gradual reduction that you are seeing. 106, you will not go directly into a 60, 70. You have the means to scan and watch it. If you are going towards the hypoglycemic range, you may need to take a small snack if at all, but you don't need to overcorrect and push yourself into hyperglycemia. And again, I'm quoting another expert who draws parallels with how you're driving the car. Now, if you're driving the car and you've gone completely to the left, right, and you think you're going to go and bang, you need to take a right turn. And if you just were caught unawares and you suddenly, at one point just woke up and found that you were on the left side and I'm going to bang into the sides on the highway, I'm going to take a rash right turn, which is how we were reacting to the SMBG for all these years. You would suddenly see a 65 and there you go eating and then we go into a 250, 300. On a real-time CGM, you're actually able to see your sugars continuously. And if you notice that you've gone towards a 70, 80, you don't have to take a rash right turn. You're going to just slowly maneuver your car a little to get back onto the road and stay there, because all of this is happening gradually and you don't need to take wrong rash decisions. We move to case study 7, a 40-year-old female. Now, this is interesting, teacher by profession. Now, typically the schools are from 7:30 or 8 o'clock it starts and then there till 3 o'clock, which means that she has a very light breakfast in the morning when she leaves home, which is tea and light breakfast. And she would take her insulin then because she doesn't want to take it in the school. In the mid-morning, whenever there is a recess or whatever, she takes another snack in the school, which is usually high in carbs. It could be poha, upma, dosa, sandwich, whatever that they get. Now, she would come to us with a structured SMBG, as we can see. And what would be seen, if you're able to appreciate here, is that a lot of her readings seemed okay. We didn't see major high excursions except for occasional ones with whatever tablets that she was taking. But her A1C constantly remained high at 8.4%. And she was on one shot of insulin in the morning, a co-formulation, a tablet in the morning, sulfonylurea metformin, a little bit of SGLT2 metformin, and other drugs like even Voglibose metformin and thyroid and other drugs. So when we see her profile, what you're able to see, the problem as to what's contributing to her A1C not staying is this mid-morning snack, right? So she's taking her insulin and her meds with this early part, which is her tea and her light snack. But the mid-morning snack, which is about 10:30, 11 in the school, is the culprit responsible. Now, what solution could we provide to her? She, of course, can't take her insulin later, doesn't prefer it that way. So one of the solutions that we may be able to provide her is to shift her alpha glucosidase combination from maybe the lunchtime to earlier with the snack. So you will have to individualize and customize and find a solution. And that's what we did for her, thinking that that's what will help probably to some extent, because her lunch is not really the spike. A spike is the mid-morning snack, which conventionally in your SMBG, you would miss out. You would do a fasting and then you will do a post-lunch. Well, this mid-morning snack, and again, she's not too comfortable checking or taking her shots while at school. So this became a genuine problem. Hopefully picking up her issue here and asking her to take a tablet at that point in time with the mid-morning snack would help. Case study 8. Well, so this is another male, diabetic, 63-year-old since 15 years, constant disparity in SMBG and HbA1c, a very disciplined senior gentleman who would come to us with decent SMBG charting, but the A1c was always out of control. And patient is on insulin and oral, and you're able to see here the SMBG charting, and A1C is 8.7. We'll show you some earlier examples. Again, every time he would come, this is from May to August, September 2022. The A1C is 8.4. We go back and we see in November again the readings there for August, whatever, September, October, November, some occasional excursions, but the A1C staying high. And then we said, let's look at the larger picture. And what do we find in such an individual? There is variability. Again, I would say ignore the estimated A1C from the A1C perspective, but you see multiple hypoglycemia that this individual is actually experiencing. And a lot of it in the night, which was getting missed because he would check his fasting sugar and he would check his post-lunch sugars or post-break, and he would see a post-lunch sugar which was 140, 150. He was clearly missing the post-breakfast excursion. He was missing the low in the middle of the night, and also, of course, missing the post-dinner excursion as being responsible for his uncontrolled HbA1c, or if I can say the HbA1c may not, in such individuals, not truly reflecting of what's happening to the sugars. And we can identify those multiple hypoglycemic episodes in the daily pattern for such an individual. Case study 9, 70-year-old female, 70-year-old female with diabetes since 37 years. SMBG shows normal readings, but A1C high in the last few months, and hence CGM advice. So again, a standard case of patient on oral medications, but persistently high A1C. And what we appreciated here, that she didn't have really any hyperglycemic excursion. There was a mild hypoglycemia in the night on few days. But why was it that the A1C remained high? And when we discussed the CGM and finding, this is when the patient reveals that she was actually snacking late in the evenings to avoid nocturnal hypoglycemia. And if you're able to appreciate, this little late 10 o'clock was actually her snacking when she's having a little surge here. Because she had experienced it long back, that fear remained and she was in the habit of snacking at that point in time, which would have led to try and increase her dose at dinner time, which was actually pushing her into hypoglycemia in the middle of the night. So again, such individuals where you're seeing disparity between SMBG findings and HbA1c, always look at a CGM picture to try and identify what's going wrong and help the patient better to get into more time in target. Now, this is case number 10 during pregnancy, well, SMBG. So you have patients who are doing beautiful structured SMBG and then marking every reading in an Excel sheet, which is getting out of control. And we've had some such patients who've done that. However, yet I would say this has been our experience of using the real-time CGM in pregnancy, where the patient gets to take action. In pregnancy, we don't have much time to look retrospective and make corrective actions. That's okay in a patient with type 2 diabetes. In pregnancy, you need to take action. Sometimes the patients will come to you only in the 7th month with high sugars, and you want to control immediately and keep it under track for the next 2.5 months. So real-time CGM is actually wonderful for patients, whether it's just for monitoring the impact of their diet and lifestyle change or oral or insulin, whatever is being used. And here we can clearly appreciate the beautiful profile that she's maintaining, which increases our confidence in what's going on. Daily scans are 16, 92% sensor data captured. Now it shows low glucose events as 19, but which is where I would want to draw attention to all of you using real-time CGM, especially in pregnancy. This ideally should be 63. Which somehow our system doesn't allow. And maybe somebody from Abbott can answer that at the end of this talk, that when will we get that provision. Again, these softwares are not officially available, but soon should have them. So it should be ideally 63 to 140. And hence you get some of the hypoglycemia falsely pointed out, because in pregnancy, a 65 or a 67 shouldn't ideally be hypoglycemia. Quickly, my last two cases. This is 51-year-old male patient, since 15 years, diabetes, persistent high A1C 11.5. Patient is on OHA. Now, this is a perfect example where we don't talk about restricting CGM use or real-time CGM use only to those who are on insulin or pumps and etc. Here is an individual who is on oral drugs, but was just not doing enough in terms of lifestyle change, taking things lightly, and the sugars remain high. So he comes to know about real-time CGM, like a lot of people are now acquiring it, and says, I want to use this rather than don't increase my treatment and my drugs, doctor. I want to use monitoring and CGM as a means to push myself to improve my diet and exercise and give me a chance and don't increase the medication. Is it fair? If you're so determined, let's do that. And see his initial profile when he did it the first time. He is only 39% in target, no hypo, and you can see the AGP profile, it's all over the place. Now, this is February, what he done between February to May. He monitors that, is convinced to start making changes. And then a little later, when we see him again, look how beautifully his profile is improving. Is it ideal? No, but definitely improvement. He's now 71% in target and aiming to do much better without any change or increase in medication. And I think that's splendid. Using CGM as a therapeutic option to improve your numbers is absolutely beautiful. Finally, this is, again, like the previous one, that lady who was going to the college and was taking some tea and snack and mid-morning. The fact is that most of our people, in fact, take tea and biscuits and then have a later breakfast a little later. And hence, very often by the time they get into their pre-breakfast zone, which is different from their fasting sugar, the sugars are already high at the pre-breakfast area. A lot of them are actually at 170, 180, like this 56-year-old male. This is the impact of tea and biscuit. Now, ideally, when you see this, you start correcting their medication. You can safely give medications even with their tea and biscuit. If somebody is on a DPP-4 metformin and SGLT2, probably you want to avoid an insulin or sulfonylurea with that light tea and biscuits or khakra or whatever. But you can very well use other drugs, because without the use of drugs, the early morning rise of hormones and the tea and biscuit is actually pushing this individual high and letting him develop a higher post-breakfast excursion. So let's start targeting the breakfast or the tea and biscuits where possible with the kind of drugs that are available, and that makes a huge impact. Finally, this is to monitor the impact of medication and lifestyle intervention, track through improvement in TIR. A 51-year-old male with history of diabetes for 1.5 years. He was on multiple shots of insulin, made changes by himself. He was advised a CGM Pro, which helped him, and we also could then see the disparity in the HbA1c and the SMBG. This is somebody who's again is work in progress. Initial profile, too much of variability. I go back in my last case to remind the principles of using AGP and CGM for guiding your patients. Improve the variability. So you're trying to narrow the breadth of the AGP graph. Stabilize them, try and get them more flatter, which is work in progress here, and only then try and reduce the exposure to avoid hypoglycemia. This, as you can notice, did not happen. So even though the patient's time in target improved, it's improved at the cost of going more into hypoglycemia, which should be avoided. So these are some of the learnings which I wanted to share that we need to avoid. This is, of course, later. This is from what we are seeing, the profile improving a bit in due course in time. So let me conclude by saying the use of CGM with time in range, it has great clinical utility and practical implications. I've been able to show you only just some. It simplifies life for our patients who are able to get the real picture. It's easy for us to recommend changes, but unless they see and they are convinced and they have the numbers in front of them, it's very, very difficult. It increases the patient's understanding about their own diabetes, their own onus and involvement in their care, helps reduce HbA1c and better manage diabetes, helps people with diabetes reduce long-term complications, and helps us reach a more targeted treatment option and thereby better clinical outcome. So with this, let me end the sharing. Okay, and hand it back to Prashant, and if there are any questions, happy to take them.
Thank you, Dr. Chawla. Fantastic to see how you've utilized CGM, not just in terms of monitoring, but also really good insights into helping the audience appreciate the nuances of clinical judgment and management. So truly fantastic. There have been a few questions, and we go through them one by one. Thanks to the audience, it's been fantastic. The questions do keep coming in, and we appreciate more and more discussions does seem very interesting. So to start off, there's a question specific to the data overload. I remember a discussion with you some time back wherein you said that CGM will also overwhelm the patient unless we take steps in the clinic to educate them accordingly. So your best practice or tips in terms of also encouraging the patient so that they don't get overwhelmed, and your tips for them.
Sorry, I missed the last point, Prashant.
Dr. Chawla, your best practices and tips in ensuring that the patients don't get overwhelmed with all of the data that they can see.
I think that's important. So while we teach patients how to look at data and see that, it's extremely important that that they don't get overwhelmed. And which is what one of the example that I showed of the individual using real-time CGM, and before we could train them how to not overreact, they would start taking corrective action, because even for them, seeing a sugar of 106 in the night would have the fear that, oh, am I going to drop to a 60 or 70 in the middle of the night, and they would start reacting to it. However, I don't think for individuals who start using it, the data is overwhelming. The data may be overwhelming for many of us clinicians and physicians who first get into it, but genuinely, diabetes management or glucose management is all about numbers. And the numbers can never really be harming as long as you're seeing the numbers. And more important with the CGMs is not just the number, but the direction. And that's a huge difference between SMBG and CGM, which will give you just a number, and this one will give you the direction.
Thank you, Dr. Chawla. Question which is also linked to this is in terms of there being any safety considerations for the use of CGM. Before I hand this over to you, specific to Freestyle Libre, the user manual does mention that in patients who have a hypersensitivity reaction to the adhesive which is used on the sensor, this could be probably the only instance where this cannot be used because of the fact that the patient will develop skin reactions. Over to you, Dr. Chawla, your take on the safety considerations.
So I don't think there have been any other safety considerations for this one, except as mentioned, if somebody has issue with the adhesive and the hypersensitivity to that, no real safety concerns. The only other aspect is, from what I remember, can this be worn while you're undergoing a procedure like an MRI scan? Probably not. I think that's the time that this has to be removed, and Prashant can correct me if I'm wrong here. And that's more precautionary, not that it has a problem with that. But otherwise, there are no safety concerns. Yes, in terms of safety concern, what the warnings and recommendations are that in case you see hypoglycemia and it doesn't match with your symptoms, an individual may still want to do an SMBG to verify, especially if you're using these in some settings like the hospital. So do we have clear approvals in the hospital for use? No, but during COVID times, a lot of us started using these sensors in the hospitals as well. There have been enough studies from the US with Dr. Ampires and group and many others. And in terms of safety, then let's just start verifying. So where you think it's not matching, both in the extreme hyperglycemia or hypoglycemia, if you doubt the reading, it's fine to verify with the glucose meter sugar reading. But beyond that, there are no real safety concerns with the device or the CGM sensor.
Thank you, Dr. Chawla. The next question is related to A1C. So you did mention during the presentation that the estimated A1C may not be the only measure to look at glucose control over months. So your take on the use of lab-derived A1C along with CGM data, and if GMI would eventually replace this with more validation, of course.
Right. So GMI seems to be a better term. I don't think the figure changes. So in terms of this, so GMI is a better term. It's a glucose management indicator. And as I said, in terms of the metrics provided, I wouldn't be giving too much importance to the estimated A1C, or for that matter, the GMI as of now. And as I said, we don't have the GMI. But what I would rather give more importance to is the TIR. And if somehow, I mean, what's lacking is if I'm still able to get a coefficient of variation or a standard deviation from these readings in the software, which some of the softwares in the world have, it would be more enlightening. In terms of HbA1c from this reading, no. Let's understand that we're talking about limitations of HbA1c, not giving us the whole picture, and hence we are doing the CGM. So let's not get HbA1c into this. At the same time, these are different metrics, and you may have more metrics which of glucose monitoring. You have your SMBG data, you may have your single fasting postprandial from the laboratory, you will have an HbA1c, and you will have the CGM including TIR data. All of these complementing each other to largely see the whole picture for the patient and help the patient better in their management of diabetes.
Thank you, Dr. Chawla. Something linked to this to conclude on the topic of considerations here. So there's a question specific to the disadvantages. We know the advantages basis all of the cases that you've seen, but instances wherein clinicians would need to be more watchful.
No, can you repeat that?
So disadvantages of CGM, we've looked at the benefits, but certain specific clinical situations where this would not be the ideal modality for monitoring, acute care, for example, or any others.
Right. So as you mentioned, I think acute care, and which also is happening now in acute care, and which is fine because the only thing, as I said, in acute care, it's more important to see this in terms of the continuity and the trend that you're seeing. But you suddenly see a reading which is dropped in terms of hypoglycemia, always best to verify. Also, well, there is some initial warm-up time for the sensor. And I would say you could take day 1 after application and probably day 14 with a little pinch of salt if you think it's not matching to the other days. So these are the 2 places where you may be cautious about what you're seeing on the readings. As I said, typically if it's not fitting into the place with patient symptoms, other readings and the rest of the days. In terms of caution, where will I not be using it? It's very, very difficult for me to say that. I'm probably a blinded believer in this whole system. I think I can only think of more and more indications of where to use this, perioperative, other aspects. Where not to use? Well, again, somebody who's had an allergic reaction, there are some people where it just doesn't stay on to them. It just comes out in day 2, day 3, and for financial reasons and others, they can't just afford to keep losing. But these are very, very small instances. There would be an occasional patient which just says that their interstitial fluid glucose, and let's remember at the end of the day, we are measuring their interstitial fluid glucose and not plasma glucose. For them, for a small percentage of patients, there is a huge disparity between their plasma glucose and interstitial fluid glucose. It could be the interference with some drugs. It could be an individual variation in that individual that we've not picked up. And somebody clearly comes to you and says, doctor, I've done this, I've tried out, I've gone to the lab, I've seen it just not matching for me. It doesn't, well, you'll have to tell them to avoid using that. But except for these occasional occurrences or instances, I don't find too many contraindications.
Thank you, Dr. Chawla. The next question, which is more of a million-dollar research question as well. So we do know that the recent clinical recommendations from the RSSDI has also looked into this, specific to the intermittent use of CGM. So your take on this and your experience.
So I think it's only the RSSDI and the Indian experts which are actually going to be talking about this, because it's still a self-pay market in our patients, and we're trying to find means of how best to use the resources and the technology that we have. And we did come out with the paper recently, as you're aware, the Indian TIR consensus with the recommendations on CGM, and Dr. Mohan was the lead author with many of us as co-authors in that paper. And we've come out with what the experts feel is a recommendation for intermittent use of CGM. And we've gone on and put it down that, ideally for patients with type 1 who are on MDR pumps, this should be used regularly. Where cost is an occurrence, you may want to use at least 4 times a year. Similarly, we've gone about and explained that what is ideal and what is minimum recommendation. But I must say, do we have strong evidence to support these recommendations? No, it's not based on evidence. It's more based on expert opinion, which is where we feel that to promote that let's use it, there are at least minimum recommendations. And for example, I would say, what is the minimum recommendation for somebody who's type 2 patient on basal insulin in India? If they can't use it continuously, I would say try and use it every quarter at least once, and that would be great enough. If somebody says, I can't even afford that, I won't want to use only once or twice, fine. So in terms of monitoring, we may have as many recommendations. We have multiple SMBG recommendations. Does anybody here in a self-pay market able to follow up? Not really. But use as much as you can would be my advice base, even for the intermittent use.
Thank you, Dr. Chawla. So the next question is, would be considered off-label. So on behalf of Abbott, we wish to remind the audience that the device is indicated for use in people with diabetes alone. So the next question for a scientific discussion. So this is specific to use of CGM in patients without diabetes. And if you have, and your thoughts on this.
So there's actually no strong data about that in terms of recommendation. But do people without diabetes monitor their sugars as a preventive thing and keeping a track? Well, many do, many with pre-diabetes, many others who are into competitive sport, marathon runners who want to keep a watch on their parameters. Right? Today, we know you have the digital and Apple watches of the world, and people are tracking their pulse and other things throughout. So is it something that we are recommending? No, but there are enough people who want to do it. And I think some of the things which are available in the direct market for use, if people want to keep a watch, they can. Is it very useful? Well, I don't think so. If somebody wants to do it once, it's fine. It's not, because if you're already in the right range, those minimal fluctuations do not matter. It matters more when the excursions are happening, when you are in the hyperglycemic range, when you are a diabetic, or for that matter, at least pre-diabetic, because that's when we're talking about loss of first phase of insulin secretion. Your natural process is not helping you and you need to track it. So people may use it there, but it's not something that we are advising on a continuous use, definitely.
Thank you, Dr. Chawla. A final question specific to the concept of integrated CGM. To begin with, on behalf of Abbott, we have the Freestyle Libre 1, Generation 1 in India, which does not interact with other medical devices. But you may have heard from media that the further iterations, Freestyle Libre 2 and 3, currently not yet approved in India, and we wish to remind the audience to look into the local prescribing information before taking clinical decisions. But the further iterations would be able to be integrated with other devices. So your thoughts on having used this across the other devices as well, and your best practices?
Well, no, I think they don't communicate. Of course, there are the DIY systems, if that's what you're referring to, and individual users using third-party applications to make sure that a CGM device is communicating with an insulin pump device from another makes. But honestly, that conversation would go beyond today's conversation. It's a whole different chapter, and it comes with a little caution and training for those who are getting into the DIY systems. But rather than that, I would hope that Abbott gets us the generation 2 and 3 sensors which communicate better and make life easier, and they actually move from intermittent scan to genuine real-time CGM. So I hope that's what happens, and we get our hands onto technology much faster, just like India got the professional Libre Pro CGM as the first country in India.
Thank you, Dr. Chawla. It's been fantastic having the discussion with you. The questions have been very helpful as well. So I'm sure the audience was able to appreciate the nuances in clinical management with the help of the cases, and the discussions and the varied topics did help in terms of shedding more light on the use of continuous glucose monitoring. It's been truly fantastic hosting you, and I'm thankful to the audience for sending in those questions, being part of our journey across the different 5 webinars. Our journey started with November 2022. You've been part of this initiative to ensure that continuous glucose monitoring is being talked about, and everyone is made aware of what's happening in the space of glucose monitoring. So thanks, everyone. It's been a wonderful, wonderful engagement with all of you. I thank you, Dr. Manoj Chawla, in spite of your busy schedule. Thank you so much for spending time with us today.
Prashant, and thank you, Team ADC, and thank you, everyone who joined in. Thank you.
Thanks, everyone. Have a wonderful evening ahead.